Well, my kids love the old, before pre-Takeda, pre-whatever, I don't know, the little foxes.
Right.
Yes.
I have a tourniquet that says Alpha on it. Does that count?
It does count.
Yes.
That's old.
Okay. All right, so should we go ahead and give this a start? I know this shrinks everyone's screen, so we can get back to chatting later on. But my name is Stephanie Simpson. I'm the Executive Director of the Bleeding Disorder Foundation of Washington. And welcome to our May virtual event series. So this is in place of what we would have done, I think, last weekend at the Mariners game. But I want to say, thank you so much to our industry partners who have been working with me since I started crazy calling them. The first time, something was closed up in the North End, as most of you know, I live in North Shore, so we were the first school district that closed, saying, oh my goodness, how are we going to make sure that we can continue to educate the community and you can continue to fund us? And these folks said, let's keep figuring it out. So I am very, very grateful. Not only did they not cut their fees, but they've been very cooperative in working with us to make sure that, this event is, and this series is funding the BDFW. And so we are very grateful. So I'm going to give them each a shout out. They're going to say hi and wave so that Zoom sees them. We'll do a couple of other announcements, and then we will see the star of the show, Dr. Kruse-Jarres. And it's amazing, which we knew, like how much things have changed since she joined us about a month ago. And always she has so much information. So I personally am really kind of looking forward to hearing what she has to say. Okay, so let's say thank you to Genentech.
Happy Friday.
CSL Bearing.
Hi.
Ripples. Takeda.
Hey guys.
Diplomat.
Hello. Thanks for letting us join.
Bear.
Hi, everyone.
Pfizer.
Hello, everyone. Thank you for letting us join.
Novo Nordisk.
Oh, that's me. Hi, everybody.
Octapharma.
Hello, everyone.
BioMarin.
Hello, everyone. Nice to see you.
And CVS.
Hi, everyone. Good to see your faces.
Yes. So thank you, because they're going to help us keep doing what we're doing to make sure we can stay strong to support and advocate for you folks. Alrighty. Now, okay. So some of the fun things is that we said if you come and get education with us, we will make dinner a little bit easier tonight. So you will signed up and gave us your email. Thank you for doing that, and updated mailing address. Is that you will receive your gift card in your email within 30 minutes of this being done so that you can go ahead and order your pizza party. I heard there was a poll between pizza and tacos on how you guys were gonna make your dinner, and it was unanimous for pizza. And those that know me well know I am a taco girl.
I think there's a few more taco votes now.
Oh, there's more taco votes now? Oof. It's making me feel better.
I vote for tacos unofficially.
Do you?
Where do you vote? How did I miss that?
I don't know. It's some fun thing Claire and Erica are doing. Okay, so we have 3 series of events. And so next Friday is we're going to get to have Mark join us from physical therapy. We had some questions about how do we stay fit and do some physical therapy activities at home, kind of monitoring things. We're also going to do a BDFW update, and some of our lobby team is going to come on and talk about what we're seeing in Medicaid, especially if you're signing up for it because of your job. How long can you stay on it if you get a job? And also some issues in regards to the exchange, such as like, where does your stimulus check go if you're applying for some of these things? If you have any questions before next week, of course, feel free to connect with us, and we'll be happy to answer those for you. We will also go over next week, like what our BDFW summer fun programs are. You probably have seen or heard that Camp Houston has decided that they are not able to provide services this summer. So we have been in the works for a while, and we're going to look at it more as like a BDFW summer versus, how are we going to replace camp, because we can't replace camp. And so why should we try? Instead, how do we make everyone feel community and connected this summer? and maybe invite some folks in to come play with us online that wouldn't come if it said camp. So we're going to have some trivia nights, campfire, variety show. And then I have not told staff this. I have this idea, or maybe I did tell them earlier today, that maybe we can do like a cooking class online, because I hear that's a new thing. This is how we spend our days. There is a post-Zoom survey, just kind of getting some questions from you guys in regards to what you need from us and how we can be more beneficial. In the future, you might see some industry questions on this. It was part of their sponsorships. But tonight, it's just about what you need from us. So please fill that out if it works for you. And once again, thank you to our sponsors. I'm going to stop my share. Does anyone have any BDFW questions? Oh, also too, I wanted to tell you industries, I had it written down and I forgot to say. So industry gets the opportunity to put in the chat who they are. They cannot reach out to you personally and say, hey, Amanda, you want to chat about that product that I told you about 3 months ago? So they can put up their information. If you would like to contact them directly, you are more than welcome to. But they cannot directly reach out to you. And so that's part of our agreement and information. So I just kind of wanted to share that because I think they're putting up their info. When we work with them, it's not just them, right? It's their whole team behind them. So we had to kind of come up with what did their legal feel was a proper exchange. And because I believe in transparency, I will tell you that we increased our booth fees this year, and I did not decrease them under COVID. And so each drug company is providing $3,000 to be with us for the 3 video series. So just because I believe in transparency. Now, is there any more questions? Okay, awesome. And I am so stoked, right? We have 46 participants. I know a lot of those are industry, but so many great people on with us today. So I'm gonna have the star of the show take over and help us all learn more about what's going on here and how to have a great televisit.
All right, let me see. Why do I have 2? Hopefully this is the right one. Let's see. Can you see my screen?
Yes.
All right. I don't know. I can't see it though.
Oh no.
Sorry, my screen is really small. So let me, sorry. But
somebody told me yesterday that I had to like pull out everything. Where it was Katie. Pull off everything and then put it back on. What did I have to do last time, Katie?
This is weird. Sorry. Let me I just don't see where to advance it, but maybe it'll advance anyway. No, it's not. I'm operating on a very small screen and there's too much going on. So
no worries.
It won't advance.
Is Katie still?
Oh, here we go. Okay, I think there we go. Is it advancing?
You can see it. Okay.
Is it?
I can see it.
Okay, so what I wanted to talk about is probably less bleeding disorders, but more what's going on with COVID. How could it possibly affect you? What are the numbers right now? Recommendations from the NHF. Gonna add a little bit to that. How to have a good telemedicine visit, because that's what we're doing right now, and we're going to continue to do for quite a while. We're going to talk a little bit about how this virus works and why it makes people clot. We're going to talk just a little bit about this multi-inflammatory syndrome in children and why that's happening. And then I really want you to understand this COVID-19 testing, because there's a lot about all this testing and what's what, so that if you're given the choice what test you should have or should not have, that you know what that really means. And stop me at any time. Stephanie, if you see any questions come up, because of my screen being so small, I don't think I'm going to see anything pop up. Just interrupt me.
Sounds good.
Okay. Thanks for having me. And thanks for everybody coming, and for everybody who's supporting this meeting. And thanks for industry to hanging in here with us. So the world has changed a lot. These are the numbers worldwide. As you can see, that's the red numbers. Just over the 6 weeks, but it's been going on longer than that. But we're now have over 4 million cases worldwide. We have almost 300,000, or at this point, it is actually over 300,000 deaths worldwide. This is a serious and real thing and reality, and we all know that. This is what the US looks like, and this is the darker the area. So the purple areas are where we have a lot of virus density, meaning a lot of infection per population. And then the lighter ones is where we see less of it. You see some right up there in Seattle, but that's stayed pretty stable, and I'll show you that. But there are some areas such as New Mexico and still the Northeast and in the South where we still see a lot of increase in cases. So in the US in the last 2 weeks, we have topped over 1 million. And unfortunately, that's been associated with a lot of deaths. We've seen over 84,000 deaths from COVID-19 as of yesterday, and that's still increasing. We haven't leveled off that curve. And that's something we want to prevent. And some people come to me and say, well, but we've had other flu seasons, and 2 years ago we had a really bad flu season. A lot of people died. How does this compare? And I wanted to show you how that does compare. So this is in the gray box. You see the influenza deaths in the US in per flu season. So we're anywhere from 37. 2 years ago, we had a really bad flu season. It was 61,000 people who died. This is for the entire season. This is for several months, and this is without social distancing. So clearly at over 85,000, or almost 85,000 people, this is more, and this is with interventions. So COVID-19 is not your regular flu. It is a lot more severe, and that's why we're in the situation we're in, and that's why we are doing the social distancing and the masking, and why our lives have changed. So just wanted to put that in perspective for people to know. In the state of Washington, we have had over 17,000 confirmed cases. People are getting tests, but the tests are not very sensitive, and I'm going to talk about the tests a little more later, what that really means when you have a test. Obviously, that is focused, again, the dark area is more virus seen, and that's going to be in King County and such, where we have more people living, and therefore it can spread more easily. Altogether, we've had not quite 1,000 deaths in the state yet. And I'll show you in the next couple of slides, we're doing better with that. So whatever, all the social distancing that's been really, really hard for us is paying off. So these are in Washington. The bars are how many people had new diagnoses every day. So there was definitely a peak at the end of March into April. And since then, that's slowly coming down. You kind of see these dips. That's probably Sundays because there is less testing going on. But altogether, we want to see that curve come down a little bit, and it's starting to. So we're seeing fewer people being diagnosed, but it's by no means zero. What about people dying? Because that's what I'm really concerned about. I mean, it's bad to have the flu, but it's really, really bad if we have people dying from this. So we saw a lot of deaths at the end of March and beginning of April. This was our peak here in Washington. And since then, that death rate's gone down. And that's really, really important. I am in the business of making sure that people don't die or don't die prematurely. So this is really important. And this is why we need to do the smart social distancing. We can talk about that a little more. What we were really, really worried about in the beginning, as things were going up and we started seeing increasing amounts of cases, we were really worried that, like in New York or in Italy, that our hospitals were going to run out of space, that they were going to be overwhelmed, and that hospitals were going to have to make a decision where somebody comes in and they would need to make a decision, this person's going to live or this person's going to die. And I got a lot of questions from the hemophilia or bleeding disorders community and say, what if I have to go to the hospital? Do I have a existing condition? And are they going to say, oh, he or she has hemophilia or bleeding disorder, and therefore they're not going to get that ventilator we have available. So I'm happy to show you that the demand or the hospitalizations have gone down. So our systems in general in Washington are not overwhelmed. Let's keep it that way, because if somebody gets sick, if you get sick, if somebody in your family gets sick, there is a healthcare system that can catch you, and there are the ICU beds and the ventilators that we may need. So right now we're still on stay home, stay safe order. And you've heard the governor announce that we're going to open up Washington in stages. The stages are slow, and I know it's grueling, and we all want our kids to go back to school, and we want to go out and play, and we want to go back to restaurants, and we want to do shopping again, and we want to have our normal lives back. But that's not going to happen for a while. So these are stages that first it's just a little bit of, gardening can happen again. People can go outside, they can go hiking. Automobile sales with certain restrictions can happen. Retail curbside pickup can happen. Car washes, house cleaning, pet walkers. And they're going to allow this, and then they're going to allow for 3 weeks to do that to see what the effect is. Because if people get infected, it takes about 2 weeks before they might show symptoms. So I cannot open up something today and then a week later open up the next step, because I will have not seen the result of the opening of the first phase yet. So if this would all go perfectly smooth, and nothing in life does, but if it were to do that, if the phase 1 started on 5/5, up there in green, you see what the timeline would look like. So the earliest things would be open again would be 7/7/20. And I guarantee you that we're not going to be there, and we're not going to be at phase 4 at that point. And I'll get to that later. This is going to be with us for a long time. So this is going to be a very, very slow, gradual process. And I just have to remind myself to be patient. I have to remind everybody around me to be patient, and we all need to be patient with each other. I know it's getting to the point where I see a lot of people that are impatient and they want their lives back, and people get snippy, and everybody is allowed to be frustrated about that. And I think we just need to be kind with each other. Unfortunately, no camp this year because of these reasons that by the end of July, I do not think that we're going to be at a safe spot. And I think it's the right decision to not have an in-person camp this year. And I really want to applaud the BDFW and Stephanie for having alternate things that are going to make this summer fun. It's going to be different, but we're going to learn a lot, and we're going to just have fun different ways. So thanks for doing that, and hopefully we're going to have a great camp next year. So then I wanted to talk a little bit, and some of you may have heard that I was seeing this in HemoWare from the NHF. They gave some recommendations, or they had some frequently asked questions, and I just wanted to go a little more into detail and say what they had to say. So one of the questions that was posed was, does having a bleeding disorder mean that you're at higher risk for contracting coronavirus? And no, you don't. The COVID-19 does not care whether you have a bleeding disorder or you don't have a bleeding disorder. I'm going to talk about this clotting a little bit later and what that means. Now, there was also a question that if you are infected with HIV, are you then at higher risk for infection with coronavirus? And no, you are not either. So HIV and coronavirus are two completely different things. Coronavirus or COVID-19 is not something that will be transmissible in the factor products. There have been a couple of blood transfusions that have been identified as, or they found that there was coronavirus in it. There is, however, of all the blood transfusions we have out there. So that's a very, very low number, and we're not sure that that would cause an infection. There's not a single case of an infection through a blood transfusion. But regardless, the factor products are all treated with either heat or solvent that would kill any virus, any kind of coronavirus. So I do not see any way a coronavirus could be transmitted through any factor product or any other hemostatic agent. So if you do get COVID-19, would that make you more susceptible to bleeds? No, it does not. There is absolutely no reason to think that COVID-19 would make your blood thinner. However, in the HemoAware, they were just talking, if you had a cough and you would have to cough really, really hard, or you're in the hospital and they have to do, I don't know, IV lines or central lines, or interventions, then you may be at increased bleeding risk because you have a bleeding disorder. So we may want to increase factor during those times. I'm only aware of one of the members of the bleeding disorders community that had COVID-19. I'm sure there are more, but certainly let us know so we can be involved. And if you need hospitalization, we can make sure that that's done safely, as with any other hospitalization. There may be an increased risk of clotting. It's unknown whether having a bleeding disorder protects you from that clotting, but like I said, I'm going to talk about that a little bit later. Should you have make any changes to your treatment regimen? Not if you're not infected. I don't think there's any reason for that. Should you have more supply of your drug? HemoAware, as well as our pharmacy, has recommended that you keep at least 14 days supply of factor at home. And I think most people have been doing that. What should you do if you have symptoms and you think you need to go to the ER, either to treat a bleed or because you think maybe you have an infection like a port infection or even COVID-19? Let us know so we can call ahead and we can let them know and say, so-and-so is coming in, he has hemophilia or she has von Willebrand disease or whatever it may be, and we can do what we usually do for you and just say, this is a patient who needs special care, here's our phone number, call us. They may or may need, not need factor, but the things that you usually do. If you have any upcoming appointment with your HDC or with your hematologist, what should you do? Call ahead because, as we said, we're doing a lot of televisits. We're seeing very few patients in our center right now. We do see people if they have acute bleeds, if they need help with infusions, if they need an acute exam. But other than that, we're offering pretty much everybody a telemedicine visit. Are there any questions up until this part? Otherwise, I'll keep on going. So wanted to talk a little bit about telemedicine at the Washington Center for Bleeding Disorders. Like I said, we pretty much offer it to everybody. And how do we determine who can participate? It's almost everybody if they want it. If somebody wants to come in person, you can still come in person. Preference for in-person visits, like I said, is if somebody has an acute issue, we usually, if we have new patients, we like them to come in because I think it's really important to meet everybody and know that there's a whole team. We all wear masks, we disinfect all the time. Everybody has to log in and make sure they don't have any symptoms, they don't have a temperature. So we're trying to keep it really, really safe so people, if they do have to come to a healthy, safe environment. Anybody who has a computer that supports Zoom and has reliable internet access can participate in a televisit. So in that case, Katrina, Daphne, or Kat, whoever is setting you up for your visit, is going to say, hey, you have a choice. Do you want to do a televisit? And if that's what you would like to do, then we're going to schedule you for that with a specific time. And then you're going to get a pre-visit package in the mail, and I'll tell you what's in there. The visits are via Zoom. We are all usually in the clinic. except for Dr. Conkle and Dr. Johnson. If they're conducting the visit, they're doing that from their respective homes. But other than that, you're going to see us in the clinic room, and you're going to be on the computer, as you can see right there. You're going to get this pre-visit package. Please call in on time because they're scheduled every half an hour. We start another meeting. So it's very difficult if people are not timely, because then everything, the dominoes fall in the wrong places. If you have a hard time during a televisit, and that's with anybody who's using Zoom, if you have a hard time and your internet is not really good and your voice becomes fuzzy or people can't understand you, sometimes it really helps to either turn off the video, because then, you know, if you don't have the video and the audio that need to go at the same time, then sometimes that becomes clearer. Or an option is to just turn the computer phone off completely and just dial in with your regular phone or your cell phone. That often helps. And please bring some patience. We're all a little new to this process, so we're trying to troubleshoot, but be kind. I have to remind myself that all the time, but we can make it work together. So good telemedicine, you get this pre-visit package. It has the paperwork in it that you usually get, such as your intake form. It's really good if you write in there who you want any of your information to be shared with. So if you have a primary care physician, we can send it to them. We ask you to update your demographic sheet so we have your right insurance. You're going to get this review of systems tool, and it's really helpful if you fill that out and send it back to us. And even if you don't have time to send it back to us, at least fill it out, because then we can quickly go through that when we see you, because we want to know, have you had any rashes? Have you had any blood in your sputum, and such and so on. So these are the typical questions we ask you, and that's just to screen you and make sure you're okay. Same thing for the physical therapy. We sent you the pain questionnaire and the hemophilia activity list. This is where we're asking you how long you can walk, can you kneel, what do you have problems with? And it's really helpful when you, if you fill this out, it's really, really helpful if you send it back to us, and it comes in a prepaid envelope, so we get it, and then we can go through that with you during the visit. And the same thing for the section for the social worker, and that is to see whether you're feeling okay, do you have enough energy, do you feel depressed, to make sure whether we can help you with any of that. And then we're going to send you a laboratory request form that you can get your labs drawn. You don't have to come to us, but you can get them drawn in a lab that's closer to you. Some of you may not necessarily need the labs drawn, but if we send you a lab form, then it's something where we just want to make sure that your blood counts are okay, that you don't have an inhibitor, that your level is okay. It's all tailored to you. And then during the visit, you're going to go, either Katrina, Daphne, Marcia, Bruno, are you going to start the meeting? Then Shannon, that you probably all know, is going to go in. She's going to spend a little bit of time with you, ask you about your recent weight. So that's also very great, great if you can get on the scale that morning, because we base all your treatment on your current weight. So we want to make sure that we adjust that right. Then you're going to talk to the nurse. Often I or the provider go in with the nurse to shorten the visit a little bit. Then you're going to talk to the physical therapist, and it's actually amazing how much they've been able to do as far as examining you over the screen then rather than in person. And if we feel like you need to come in for an ultrasound for a better exam, then we can always talk about that then. And then lastly, you're going to see Kat to make sure that there are no social work related questions. Any questions about televisits? Any comments about that for those of you who have done them? Any recommendations for other people who are going to go through that?
Yeah, I had a question, doctor. So when we talked about that, there was, I believe your center was the first to send out patients, a group of them, on a trial basis of ultrasound machines at their home.
Yeah.
Are you guys having a lot of success with that during this time?
Yeah. So we are actually conducting a study because my big vision is that one of these days, or hopefully over the next year or so, we're going to convince insurance that all of you need to have a little handheld ultrasound at home. So that if you have an acute pain episode and you don't know, is it a bleed, is it not a bleed, you can go ahead and you can hook it up to your phone or a tablet, and you can communicate the ultrasound with us and you don't have to come in. So it's something that we needed to show that can we teach you to do that. So that was the first phase of the study, and we just completed that, and we had 10 people who sat through a 6-hour training session, but they all demonstrated that after that they could do all the maneuvers and they could perform the ultrasound proficiently. And then they went home, and then we actually did this with this tele ultrasound, and again all 10 of the participants were able to do that. So that was a very big thing that we were able to prove that yes, it can be done. The next thing we're doing right now for the next 4 or 5 months is that we're validating that what we see here in the shot we call here, if we call something a bleed with that, is it really a bleed or not a bleed with a big machine? So we have 10 people who have those units at home right now, and whenever they have a painful episode, we do the tele ultrasound with them and we decide on, is this a bleed, is this not a bleed? And then they come in within 24 hours so we can confirm it on the big machine to make sure what we're seeing is really what we're seeing.
Yeah, I think that's great.
Yeah, I mean, but once we have that validation study, I think this is going to be so important to get the buy-in from insurance. Without the validation study, they're going to say, so what does it really mean?
Loud, right?
I'm sorry?
Oh my gosh, sorry.
So anyway, so hopefully we're going to have the results of that second part of the study by the end of summer. It's pushed back a little bit because of COVID and difficulties getting in. So hopefully we're going to have that, and then we can start talking to insurance and get this as a more widespread.
I'm gonna find your name. Oh, Diane.
Hey, Rebecca, I have a question.
Yeah.
You had and all the numbers of people who have COVID-19 in the state and in the country, and do you have any numbers of in our community, the number of people in our community who have it?
That's a really good of people with hemophilia or bleeding disorders.
Yeah.
I only know of one person, but that is, I have not sent out any questionnaires. I have not contacted all of you to find out, have you or have you not? I have only heard of one person. Usually with most of our patients, when they're going to the hospital, often I hear about it. So I haven't heard of anybody, but that doesn't mean that the number is not higher.
Right. So you can't say whether or not there are any extra complications because of having a bleeding disorder or anything like that?
No, I can't.
Okay.
So I looked at the data from, Wuhan or Italy to see whether there is anything that would be different in people with bleeding disorders, and I'm not getting enough data to say anything about it. I can tell you that there's not an overwhelming amount of people with hemophilia that seem to be in the hospital, but I just don't have enough data to really tell you if you're safer or you're less safe. It seems like there are not more complications in people with hemophilia.
Yeah, we're probably a pretty cautious group to begin with.
Absolutely right. And maybe, even though I have no idea whether that's true or not, but maybe there's a little bit of a protection in having a bleeding disorder. And I'll get to that next when I'm talking about the clotting.
Okay, thanks.
Sure. Any other questions? All right. Well, then let's talk a little bit about how this virus works, because that's important in understanding what it can and cannot do. And just to let you know that this is knowledge that's changing every minute. This is just the state where we are right now, and this is what we're guessing how this works. We think that this virus hooks up or binds to what's called an ACE2 receptor, and I'll show you where those are. So we know that these COVID viruses live in bats. That's, there are all kinds of different strains, and COVID-19 does not mean that it's strain number 19. It just means that it was discovered in 2019. So there have been lots and lots and lots of coronaviruses, and we know that they do live in bats. They're called coronaviruses because they have these spikes on them, and somebody said, oh, it looks a little bit like a crown. So that's where the name comes from. We also know that there are some domestic animals, not very many, but that have been infected, it seems like. We have no idea whether the virus, maybe there are some animals and some wild animals that were infected from the bats. And maybe this is how it got onto the Chinese markets, where they take a lot of wild animals and do all kinds of things with them and eat them. Is this how humans got it? That's currently what we're thinking. I am much less impressed with the theory that it came out of the high security viral center where they did research with it. I think that the thought that it came from bats that infected wild animals, and that's clearly been shown that they can, and that humans got infected that way, to me, it's the most likely scenario of what happened. And that's where Ebola came from. This is where a lot of viruses came into the human race. So anyway, so this virus then will bind with, you'll find S proteins, M proteins, N proteins, E proteins. There are all kinds of proteins that that facilitate binding to this ACE2 receptor. We have a lot of these receptors in our lungs, and that's why it helps for the virus to get into the lung tissue. So there are also other molecules that help with that, but it seems like it's this human ACE receptor. People who are elderly or people with some underlying diseases do that more readily than others, or they're more affected by it. And that's why we see this as a disease that is affecting or is more severe in older patients versus younger patients and children. I'm going to talk about children a little bit later, but it seems like we're particularly worried about people over 65 years old because it seems like those are the people predominantly that are dying. And that is partially due, it's not necessarily the virus going into the lungs or any other tissue, but is the immune response that our body makes in response to that. And that is called the cytokine storms, where we're releasing a lot of cytokines. You get into this overwhelming inflammatory picture that can lead to people not having enough oxygen, septic shock, and beyond what's happening in the lung, we're going to talk about that something similar, it can happen in the brain and lead to strokes. So people who have underlying hypertension, chronic lung disease, diabetes, or other heart disease are at higher risk for dying from this disease and having ill effect from the cytokine storm. Severe complications, like I said, mainly it's this respiratory disease, but it can, in rare instances, have other scenario. Coagulation dysfunction, we're going to talk about in the next few slides. So like I said, the hypothesis is that you have this coronavirus, it binds to this ACE2 receptor, and that's how it gets into the cell. So we have an ACE2 and an ACE or angiotensin 1 and angiotensin 2. There are two enzymes that need to live in our system in balance. And if that balance is okay, then your kidneys are working fine, then you're constricting your arteries the way you're supposed to, and you relax them when you're supposed to. So it's just for our entire well-being, it's really important that we have these two enzymes in balance. So if we have something that's binding to some of these receptors, they're taken up and then we get off kilter. And that is what's causing a lot of problems. It's not just causing the cytokine release, but it also seems to cause a lot of coagulation disturbance. So in that case, we get people that have this overwhelming clotting picture when they're sick. So it's been demonstrated in several studies, and I'll show you this one here, in people who are in the intensive care unit, that almost 20 or 22% of those people died, but over half of them had clots. So whether that was a clot in their lungs, or it was a clot in their legs, or it was a heart attack or a stroke, but it seems like people who get who really get sick with COVID, they just get this overwhelming coagulation, whether it's from the inflammation or the inflammation is driving all this extra clotting, we're not sure. So in these people, because they saw this early on, they said, well, let's put everybody on blood thinners. So that's of interest to anybody with a bleeding disorder, because you don't want to be on blood thinners, but they're trying to prevent all this clotting from happening. So what they did initially was just kind of a lower dose blood thinner, and it didn't really make much of a difference. So the next question is, do they need to be on higher doses? So if one of you needed to go to the hospital with severe COVID, they might want to put you on a blood thinner to prevent this from happening. And then certainly we would need to counteract that with replacing whatever factor is missing. So that's why I really, really, really want to be involved if any of you were to get sick, so we can make sure that we handle the balance right. Are there any questions about that?
I had a quick question.
Yeah.
So, if you needed to have a surgery for any reason, and you know, through that whole process, does that put you in any additional risk? Is there, because of this, what's going on, is that even a factor at all?
You mean to contract the COVID-19?
Either having it or contracting it, yeah.
So what they do now is that if you needed a surgery, they would look, you know, is the surgery really needed right now? Is that something that can be postponed? And anything that can be postponed is being postponed. So let's just say it's really, yeah, we really need to do the surgery. They check everybody for COVID-19 right now before they even do the surgery, whether you have symptoms or not, because they want to know whether maybe you're one of those asymptomatic people that still has COVID-19. They now, in most hospitals, are really well supplied with these personal protective equipment, such as masks and gowns and the face shield. So most of the time going into the hospital right now, you have the feeling you're in outer space. So people are very aware. Most hospitals also try to have the COVID patients in one section of the hospital and not in others. But regardless of that, there's an increased attention to hand washing, wearing gloves, changing the gloves, and being super careful and clean.
And that's probably true of being on the floor as well, and in the ED. Okay.
Right, exactly. It depends on the hospital, and it varies from hospital to hospital. And I can only speak for places like Harborview and the university, but they're Swedish. They're all being very, very careful.
Okay, cool. Thank you.
Sure. All right, so then with all this clotting, I wanted to also talk a little bit about these. There have been a couple strokes. There have been a couple of strokes in younger patients that otherwise were doing totally fine. And they are related to COVID-19. And the thought is that we do have these ACE2 receptors in the brain as well. So the virus could potentially, maybe it's affecting the lung a little bit, but not to the point where it's causing symptoms. But if it gets into the brain, it binds there enough and causes enough of this imbalance between the ACE1 and ACE2, do we then have tissue injury that in the brain, in the vessels in the brain that cause strokes in patients? The incidence is very, very low, but we certainly have seen it, and it seems like there is a link. So it's one of those things that can happen, and the COVID-19 certainly does not seem to just affect the lungs as we thought in the beginning. What about COVID-19 and children? So far, we thought, oh, children are totally safe, and it seems like it's not affecting them. If they get symptoms, they're really, really mild. They're not the ones that are dying. It's really the elderly, the ones over 65. And that by and large is true. However, kids can get really sick. There is something called a multi-system inflammatory syndrome in children, named for that because they don't know what's causing that. They don't know who is getting that and who's not getting it. The thought is there is an inflammatory response in the walls of the arteries, and it's actually acting. There's a similar disease called Kawasaki disease. That's an inflammation of the arteries. It looks exactly like that. Till this day, we do not know, or we don't know yet how this is happening and what kids would be at risk or not. The reason why I'm bringing it up is not because it's very common and not because I want to scare you, but I think maybe a month ago, if you would have asked me, should kids be super protected or can they play with their other kids in the neighborhood? Well, probably not. And I think even with our kids, we just have to be careful. Kids don't like to wear masks, but if they see the adults wear the masks, then maybe they're going to do it too. And we just need to be careful because we don't want this to happen to anybody. And if I find out more about it and what's really causing that, I will certainly give you an update, but that's all we know at this point. Any questions?
Rebecca, I just wanted to add that Dr. Blair is meeting with everybody 2 Fridays from now.
Okay.
So between Dr. Blair and you, that maybe some more will be revealed about that hopefully.
Yeah, I know that. Yeah, that sounds great. Like I said, I mean, whatever I'm saying right now, there's probably already more knowledge out there. Right. It's hard to keep up with, but we're discovering all this together as we go.
Yeah, no, absolutely. I just wanted to give you that update, but then also too, if anything presents, where I'm sure one of you can update tomorrow next week.
I'll definitely let her know then too, that she can make sure that she can bring that to the group.
Okay, awesome. Thanks so much.
Okay. So those I've been asked a lot about what COVID-19 is doing to the pipeline, to clinical trials. So far, we are in contact with our industry partners on a regular basis to make sure that there is not a problem with manufacturing factor of emicizumab, whatever it may be. And so far, we're not seeing any concerns. Should that happen, I would certainly let you know, but I think the supply is very secure. The pharmacy at Bloodworks continues to work in 2 different teams so that they're not cross-covering, and we're not going to have COVID come in and infect the entire pharmacy, because I want to make sure that you're all safe and supplied for. What does COVID-19 do to clinical trials? For a while, we kind of halted all the clinical trials and said there's no need for somebody to come in for a trial visit if it's not urgent. We have a couple of people who are on gene therapy trials right now, and obviously they came in or they're continuing to come in to make sure that they're safe. But we would not start anybody on new gene therapy right now. So there are a couple of trials that are they're still open, they're still okay, but they're holding the enrollment right now to make sure, because if you get on gene therapy and you need to be placed on steroids for a little while, that might be adversely affecting you, and we don't want to do that to anybody. So once we're over this pandemic, I think these clinical trials are going to start picking up again. Any questions on clinical trials?
Well, if it counts, trials like on antivirals, like remdesivir, community members have asked me, is there hope in antivirals, or which ones do you find that are being employed today that really help the situation with the COVID-19?
Which antivirals?
Yes.
So there are several antivirals that are in clinical trials, and until we have the data, I can't tell you. There are some of them that are looking very promising. They were given randomly, not really with clinical trials, but some of them were used in the early days in Wuhan, and it certainly seemed like some of them were promising. But I really think we need to wait for the clinical trial data before we really know whether they're working or not. But pretty much, if you're sick and if you're at UW, you would be invited to be in a clinical trial. So the clinical trials I'm talking about here are all hemophilia related. They're not COVID-19 treatment related, if that makes any sense. I hope it does. All right. All right. So, and then I just wanted to, I have a couple of slides on testing because that gets really confusing, and I want to make sure that everybody understands what testing is available and what these tests can and cannot do. So by and large, there are two different tests. One of them is a viral test that actually sees whether you have a virus at this point and therefore you have a current infection. That's called a PCR test, or a PCR stands for polymerase chain reaction. That's just a way how you amplify that virus to actually detect it. So these tests are, they are now available. They're not or they're not 100% sensitive, meaning if you get a test and it's negative, it does not 100% exclude that you really have COVID-19. And that's really important to know. Then there are tests, there are antibody tests, and the antibody test is checking for the antibody to the virus. And that tests to see whether you have had that infection in the past. So it's kind of checking the immune system to see, have you started making antibodies against it? If you do make antibodies, you may or may not protect it from reinfection. We think you probably will be, but we don't know that 100%. And you probably have read in the news over the last couple of days that there's this rapid PCR test where you get results within 15 minutes, and that test is having major problems. So if you were tested with that, or anybody who's being tested with that, it does not pick up about 50% of actual infections. So there are a lot of people that were tested with that, and that's what they use in the White House right now. But they have to rethink what they're doing, because I think people in the White House, especially the president, is getting tested daily, I hear, and that's what they use. So all those negative tests really don't give us a guarantee that he or the staff does not have COVID-19, and maybe that's why there were 2 staff members that actually did eventually test positive. So if you do get a test, make sure that you ask how sensitive this is. Any questions? So when do they turn positive? This is a little bit of a confusing graph. And can you see my cursor at all?
Good job.
Stephanie, can you see my cursor?
No.
Yep, I can see your cursor.
Okay, perfect. So in the gray area here, this is the time when you might have, this is right before symptoms. So you could be infected and the virus is starting to go up in your system. And the closer you are to getting the symptoms, and this dotted line is when you start having symptoms. So here are all these solid lines. The solid lines are the PCR tests. And it depends on where you test it. So it can be, most of the tests are those nasopharyngeal swabs. Those are the ones that you see where they almost seem to pick out your brain. They go up and they should be highest at the time when you have symptoms. It could be that they're positive before, but it could also be that they're negative if you're 2 weeks out. So you could have virus and it's not going to pick it up. So they're going to be up for a week or 2, and then they're going to go back down. And it's no longer, the virus is no longer present, then the test is not going to.
For 1 hour.
Please turn off Shina Lockhart, please.
You have a competing guest.
Please.
All right. So, and then you have the antibody tests. And then the antibody test is going to go, that's not going to go up until your immune system is starting to respond. And then you get these IgG here in green that's going to go up, or an IgM. That test, I don't know whether it's available yet. That's going to be an important test because that's one that's going to go up, but that's going to go back down. And it tends to be a very sensitive test. So I hope eventually they're both going to be available. Right now, the IgG test is becoming more and more readily available, and it's a relatively good test in most laboratories. LabCorp is having it. So the viral test right now is only available if you have symptoms. If you have symptoms, then you go to your primary care physician or any physician, and then they will, they can order it for you. The antibody test is for anybody who had the symptoms, and LabCorp has it available. To get it done, either you need an order from your primary care physician or from your physician, or you can go to the LabCorp website to this PWN Health. That's a physician service that can then order it for you. That service will cost you $10. So if you really want to know whether you have antibodies, that's something you can try out, and otherwise just go to your physician and then they can order it for you. And again, that test is just going to tell you if you had maybe a month or 2 months ago, you had flu-like symptoms, that would be something that would tell you whether you had COVID-19 or not. Any questions about testing? If not, then I want to, I have 2 more slides, and one of them is that to tell you that pandemics like this are not new. We have not seen them in a long time, but a lot of you probably heard of the Spanish flu, where I will inform you that the Spanish flu did not originate in Spain whatsoever. It came, or it started in Kansas. The reason why it's called the Spanish flu is because in 1918, you may remember there was a world war, and that was more important, and that was in the front of the news and not this flu that was kind of going in the background. Spain was not involved in the First World War, and for them, the flu was really important, and therefore it dominated their media, whatever they had, newspapers back then. So because it was reported more in Spain than anywhere else in the world, they called it the Spanish flu, but it did not actually come from there. But what I want to point out here is that, this started being a lot of people got infected, a lot of people died. And then people this was in October, November, and over here you can see what happened in Denver. So a lot of people got infected, and then they started having interventions where they said, oh, we need to distance, we need to clean our hands, we need to be more cautious. As soon as they removed these interventions, they had a second spike. You don't see it here on this graph as well, but in Denver you do. And here you also see, eventually that went back down as people were wearing masks and they were being more careful. But then by February and March, there was a second spike because people were not adhering to the distancing and the mask wearing. So it is really important. And I think if we are going to go out there and we're going to think that life is going to be completely normal, and we're not going to have some social distancing and mask wearing, we're going to see another spike and we're all going to be back in our homes. We don't want that. I think we need to get this economy going, but we need to do it very smartly. So I think wearing a mask in a supermarket is an appropriate thing to do, and it's not to protect you, but maybe to protect the apple, or you don't want somebody to cough on an apple that you are then going to buy and you're going to get the virus. So you would want somebody else to wear a mask, and therefore I think it's appropriate for all of us to do that. I think it's going to be appropriate to do that when we go into any kind of public space that's especially indoor. I think it's the right thing to do when restaurants open up again, that we're very conscientious about where we're sitting and how close we are to people. It's going to be with us for a while, but everybody hang in there. Stay healthy, stay kind, and if you have any questions, I'm around to answer them.
Awesome. Before we take questions, if it's okay, maybe if you unshare your screen, then everyone can see.
Yeah.
Folks for question time, because that's always lovely.
Yes.
And then people can either, ask their questions, raise their hand, or put them in the chat, and we can help facilitate that. I'm getting some thank yous. Anyone have any questions? Anyone have any questions outside of Rebecca?
I do. I have a question.
There you go.
We live on, this is Ivan Niegas.
I know. Hi, Ivan.
Hi, how are you?
Ivan was your first patient.
I know. I will never forget.
How sweet.
So nice to see you.
It's so great to see you.
So Ivan has had 2 negative COVID tests. He has all the symptoms except for a congested chest.
I don't know what the diagnosis.
So the diagnosis is upper respiratory viral infection, and it comes and goes, and it becomes very vulnerable to being, what do you call it? Just knocked out, no energy, and then starting to cough and stuff.
But I had a chest X-ray, and that showed all clear. And
so that's really good, because it seems like the chest X-ray, but in particular the chest CT, has very, very telling pictures for COVID-19. So for a while we had this idea about, do we need to do a chest CT and this PCR test together to really know whether somebody has COVID-19? I can tell you that of all the people being tested, only about 7% are turning out positive. So these are people exactly in your situation. They have symptoms, they have respiratory symptoms, cough, they may have flu-like symptoms, fevers, and that's why they're getting tested, because asymptomatic people by and large are not getting tested right now. And only 7% of these people are turning positive on the test. So if you continue to have it, I think it's an appropriate thing to continue testing periodically. And certainly I would suggest to your provider, if you're having these symptoms, wouldn't they want to do a chest CT? Because chest CTs seem to have these telling signs that are very typical for COVID-19.
Thank you.
Thank you.
There's a question in the chat, and you chatted about this a little bit, and the person said that they're doing it at work, so they might have missed. But this is a little bit more specific, knowing if we've seen the pediatric inflammatory disorder in Washington.
I have not, and the ones I read about, there was a kid in the UK, there were a couple of kids in New York. I would have to ask Amanda. I'm not aware of anybody at Children's.
Okay, and somebody else, Devin, is asking the best place to acquire masks, gloves, hand soaps, and hand sanitizer. The BDFW is getting hand sanitizer in, so if folks need that, they can always message us. We ordered that like months and months ago. But maybe other folks have had some success with mask, gloves, and hand soap. If people need a mask and they're not able to afford it, I think that's something that would be a reasonable thing for us to help get somebody. But some of those other things, if folks are having great luck, share your words of wisdom and your secrets if you're willing.
And actually the hand sewn masks are really, they're recyclable and they're really, really great and they're very effective. So what I do is I just have a mask, and I just, when I'm driving around, and then I go to the grocery store, I put it on, and then I get back into the car and I put it in a plastic bag. If you let it sit for 3 to 4 days, the virus in there will be dead. So it's as good as new after that. So I have several masks laying around in paper bags or plastic bags to make sure, because the last thing I want to do is have one that I wore in the hospital and maybe it has virus on it. I don't want to take that into the next patient. So, but that's one way to do it. This virus hates soap. So just washing with soap and water is very, very, very effective. It's as effective as hand sanitizer. So it doesn't need the hand sanitizer. The hand sanitizer is great when you're traveling. So that's an alternative. And I think that the sanitizers and the masks are becoming more freely. Oh, look at Kevin with his. That's great. Yep. See, exactly it. And they're becoming more available again.
Mm-hmm. I've even heard of Lysol sightings in the last few days.
Oh, there you go. Slowly but surely, it's all coming back. I heard of toilet paper. No, I'm just kidding.
I know, right? Low on meat, one per chicken per Costco run, but
Chicken per Costco.
Rebecca, this is Danielle. To that point, I'm curious about wiping down groceries or takeout delivery food or anything like that. I'm not so worried about myself, but for my parents, is that something that should be done, or?
Yeah, so it all is how much risk are you willing to accept? And certainly for my 80-plus-year-old dad, I'm not accepting any risk. So the virus on plastic can live for up to maybe 5 days. On cardboard, it's a lot less. It's maybe only hours to maybe a day or two. So you're probably, if you get a pizza, it's probably okay. If you get an Amazon package and you really want to play it safe, then just kind of kick it in the door and let it sit there for 3 days before you open it. At that point, there should not be any virus that can contaminate you. So what about apples, any fresh fruit, salad? So I usually buy my apples. I let them sit for 3 days before I eat them, and then I eat them. Because I'm not sure, I'm certainly not going to wash them with soap. I don't think that would taste so good, and I'm not going to use hand sanitizer or alcohol on them. So I think that's one way. Same thing with the broccoli. I just put it in a bag. I leave it in the bag for about 3 days. Or if I know that I'm going to cook it anyway, I think then that's going to kill the virus. The virus does not like heat, very hot heat, but it can live in cold. It can potentially survive in the fridge and in the freezer.
One of the things I've been wondering about is items like peanut butter, things that are oily in our foods. Can they hold the virus?
No, the peanut butter, the virus, if it can't infect, it's not going to survive or not likely to survive in any of those sealed groceries for very long. So I doubt that you would ever find live virus in a peanut butter jar. It really needs that live transmission from, human to human, or from animal to human, or human to animal. Where we know that there are a couple of cats that have been found to have the virus. There's a tiger that had the virus. But we do not know that these animals can reinfect and bring the virus back to humans.
Multitasking.
I do have another question about Bruno and physical therapy during this time. Can we receive some help from him online?
Absolutely. Yeah, he does a lot of that. Just call in and schedule an appointment with him, and then he'll do a televisit. So we'll just set up Zoom meeting just like this, and then him or Mark will do their best to assess you. Some of that is that they might ask you, or to get up and do certain movements, or say, well, show me how well you can move your arm, and then go, well, go to this part of your elbow and push here. Does it hurt there? So he kind of is trying to do the assessment via you.
Thank you.
Yeah, sure. I think we're never going to go back to complete 100% in-person visits.
I think it's great though, because sometimes it's so nice to see someone's face, but to just ask the question, and to get services faster. I mean, you need both.
Yeah, there are so many great things about telemedicine. There are so many things I'm missing. I mean, sometimes for me to touch a joint tells me so much about that joint, and I'm missing that. I'm missing the physical contact, the hug, the hey, how are you doing? There's something about being in person that I very much miss. But I think there are so many great things. I see you in your home, you see me in my home. I like that.
Yeah.
The other day I did a visit on a houseboat that way, so it was great.
There's always pros and cons to everything.
Yeah.
Right, but yeah, we're actually we're really monitoring telemed legislation. They actually pushed through lots of different things so that these services could be provided quickly, and our team was working on those. And so we're looking to make sure that they continue to be in place, so people can utilize those services and I have heard from folks that they've finally been able to get some people they always wanted to get connected with you, to get them connected with you, because it was like, hey, let's just get on the phone or, you know, do this in telemed. So it's a great first step for a lot of different things. So
I have more new patients and more visits now, partially because I'm not traveling, and partially because it's easier for people to visit this way.
Yeah. That part of it is exciting. The more access we can get, the better. So, what about some more questions or thoughts? Questions pertaining to this or anything else?
Hang on, say if someone has had the virus, what information do we have regarding a reinfection or resistance? That's a really, really good question, Devin. Thank you. Immunologically, so coronaviruses have been around forever, so we kind of know how they behave and we know what our immune system is doing with them. So if we're going from what we know, we would anticipate that this is going to do the same thing. Do we know that? No, we don't know that 100%. But if it's doing what other coronaviruses have done, then our immune system is going to make these IgG antibodies for a while. We don't know how long that would last. We don't know whether that's going to last a year or a lifetime. But in that case, when we have these IgG antibodies, we would not anticipate that people can get infected again, or if they would get infected again, that it would be a very light infection. That's usually how immunology works. Now, could it be that this guy is going to do something different? It could be, but that's what we're anticipating. I think it's really important. You probably heard about the convalescent plasma, some of you. So the idea behind convalescent plasma is that they approach people that have had the virus and they collect their plasma and then they store the plasma and they give it to people who are really sick with COVID-19. Because the idea is that these antibodies that live in the patient's plasma who has recovered can now fight the infection in somebody who's really sick who doesn't have an immune response to it yet. There's a lot of reports of positive outcomes, but again, this is in clinical trials and we're gonna have to be patient and see how that pans out and whether that really is helpful. But I think that would tell us a lot about whether you can get reinfected or whether you would be resistant after. I hope that answered the question.
Mm-hmm.
Yes, I have another one. We've had trouble with our medical portals, able to communicate what tests have been taken and what results and when the next appointment is and all that. How do we combine events that happen at different locations all together?
That's a good question. So this was part, or it was supposed to be part of a solution that I think the Affordable Health Care Act was trying to get to, that we're all living in these different pockets and everybody's going to a different hospital and now you're getting one care here and then you're going over there and they're not communicating with each other. So the whole reason why we now have these electronic medical records or EMRs and we're all sitting in front of computers and we're not writing things down on paper anymore is partially because the hope was that all these computers would talk to each other. And therefore that if you get something in one system, the person in the other system will know that. Unfortunately, a lot of these systems are really not communicating well with each other. They're continuing to work on it and they're continuing to work to find hopefully one day one system that will do it all. They're a lot better than they used to be, 4 or 5 years ago, but we're by no stretch there yet.
Thank you.
All right, we have probably time for one more question. If anyone has one. Lots of good questions.
Very good questions.
Do you see that one?
Yeah.
Okay.
So that's a lot. Yeah. So it's along the lines of what advice do you have to educate people or help people who aren't as worried as maybe we are to take things seriously and the boundaries seriously. And I think that that's a big problem. I think we are all in this together. It worries me that some people are getting way too close. It bothers me if I go to a grocery store and there is somebody without a mask coughing away. We need to solve this as a community. And sometimes it's very easy to talk to somebody and say, you know what, I don't feel comfortable with you being so close. And nothing against you, but this is what we do right now. I think it does help, and some people hate it that the governor says, oh, things are closed, or we need to wear masks, or there are all these guidances. They're not there to make our lives difficult, but they're there to protect people. And it's very difficult for some of us to advocate for ourselves and say, I don't feel comfortable when you're not wearing a mask. But you do need to advocate for yourself and to say, please, I don't feel safe. Please do this. It might be that you're a superhero and you think you can't get infected, but you're making me feel unsafe. And I think that's okay to say. There are too many coming in. Hang on.
I know. Yeah, somebody has shared that that they've seen people say, like, wear shirts or a sign that says, I'm at high risk, please be respectful of me.
Yep.
That's like a really great way to do it. I was at the store and like the grocery clerk didn't have a mask on, like that was working he was younger, right? And I was waiting. He's like, oh, so sorry, I'm in your way. I'm like, no, I respect you and I value you, so I'm waiting until you're done, right? Because he was doing his job, so I was trying to like pass that off. Because when I go to the store, I'm like, this may take a while, right? Like I shouldn't go anywhere in a hurry. And that's kind of been the line I've been using. Like, no, I value you, so I'm going to wait until has to be done, But
yeah, I mean, the first step I had to do is just to say, I can feel on top of the world, but you know what? When I go to a grocery store, I should still wear a mask. Mm-hmm. It's the security that I give to others.
I'm curious, and I don't know, moving up here from California where we were, masks were required everywhere, even walking or exercising. And it was super weird driving up here because we went through the Taco Time drive-through and there was no masks on anybody. And it's been a bit of an adjustment. Is there any reason why the governor hasn't mandated masks here?
Well, I'm glad I'm not the governor here because, or any governor for that. It's a really tough time, and people are not all on the same page, and there are a lot of really angry people, and every restriction is going to have a lot of people that are going to be against it. So there is either later on, was it today or next week, I think there's a guidance coming out to wear a mask in any public place. It's not a law, but it's a strong guidance.
Good. Good to know. Good to know.
Yeah. Dwayne, are you now a normal person again?
Yes, I've taken off my industry hat.
I love it.
I'm just reading. It looks like people are kind of chatting about masks. Any other burning questions, or we're at the time that we allotted? I'm happy for people to stay on and chat, and as long as as people want to. Super fun to see. Like they posted the post survey Zoom. And it would be great if you did this because we're going to do more of them and we'd like to kind of test it out. So if it didn't work, then we want to know. But as always, I really want to thank, Rebecca for her time. She's just so generous with that and always has been. I have a question. Can we get an email of the slides? I missed some of the beginning.
Yeah, happy to do that.
Yes, and we also put all of these like more educational Zooms on our website. So if we can put the slide deck as well, just so other people can go and get them, or you can re-listen. So we're happy to do that. But yes, so people can hang out. And yes, thank you so much for your time, Rebecca.
Yeah, anytime. And thanks for having me. And great to see all of you.
Yes.
Great to see you. I have question. It's Khatra Mohammed.
Hey, how are you?
Good. We have question, me and Adam. Adam didn't have dental for a while, and he has his wisdom was heard in him a couple days ago. But do you think they will open like slowly, because our other dental they open, but I don't know.
Yeah, dental is particularly difficult, right? Because you're having to work in the mouth, and it's not like you can wear a mask while somebody is examining your mouth. So they're opening up slowly, but I understand that dental hygienists and dentists are concerned, and they have every reason to be. So I would just, if there's nothing urgent, I know that they're taking urgent patients, but if a cleaning is pushed back a little bit, or the wisdom teeth are not causing any problems right now, it's okay to wait a little while, and hopefully, it's going to be a while before we have a vaccine, and it's going to be a while before we're out of this situation. But if you can wait, I would.
Yeah. All right. Thank you very much.
Are there any
there's one.
Yeah, for an ortho appointment. Depending on where it is, I would just make sure that they have masks, and that they screen. Most hospitals really don't even let you in unless they ask you all the questions about the fevers and the cough and the diarrhea and whatever else, and taking your temperature, even though I think taking your temperature does nothing, because it's going to miss a lot of COVID-19. So it's not an absolute. If they don't take your temperature, that's fine. But I think I would want to make sure that they're all wearing masks, and that you have one when you go, or that they provide one for you. I'm sorry, it's orthodontist. So sorry. So orthodontist, different story. And if they're open and they provide you with an appointment, then I would definitely go, but certainly make sure that they're wearing a mask.
Alrighty. All right, well, if there's any more questions, or you all just want to chat and say hi to each other. And I love these, because we always have people that come on that we have never had at BDFW events before. So I've been saying, no matter what, I think that online education will continue to be a part of the BDFW repertoire, just because it's just so fabulous to be able to connect with folks that we don't get to traditionally see. So, this is awesome. Alrighty. Anything out there that people want to see in the next 2 weeks that we don't have planned, but that we need to get answered for you, or fun ideas?
Yes. I don't know about fun ideas, but I just had a question regarding one of the slides we saw, which talked about having a 12-month supply at home.
2 week. 2 week.
2 weeks. 2 weeks.
Yeah.
And if it's gone out of date, can we get fresh?
Yes, you can. Now, Factor, as we know, is still working. I mean, if you really needed to use it and you have expired Factor at home, it's still working fine. And industry didn't hear that. La 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 la. But certainly let us know if it's outdated. Then we can always make sure that you have an in date at home.
Great, thank you very much.
Rebecca, there was also a question, are cancer patients at higher risk?
For COVID-19, not that we know of. And that is not, the cancer is not one of the comorbidities or other diseases that people may have that has been associated yet for worse outcome, but it very much depends on what kind of cancer. I mean, if we're talking lung cancer and somebody can't breathe, then obviously that would not be a good situation. If somebody has like a basal cell carcinoma or a little skin cancer, I don't think that would put you at any increased risk.
If you've had radiation or chemotherapy, though, your immune system is probably compromised?
So Mike, this is a really, really great question. The same thing, not just with the chemotherapy and your immune system being compromised, but also people with autoimmune diseases who might be on immunosuppressants, such as prednisone. At first, there was really a scare, are these people at higher risk for getting the virus and for bad outcomes from the virus? So getting the virus, or once the virus is there, for the virus to enter your system, probably. And there's not a lot of data on that, but there's a thought that if somebody is immunocompromised, the virus probably has an easier time to get into the system because your immunity would not be as strong to hold it back. But what do people die of? They die of these cytokine storms. And there now is a thought that maybe people who are immunocompromised or are on immunosuppressants are not going to have that cytokine release that somebody else would have, and maybe that's going to serve as some protection. That's a thought. There's no proof.
Yeah. I'm just being told by my oncologist, since most of you know I've had a bout with cancer last year, that since I've had radiation and chemotherapy, I should not go out until phase 4. I should be treated the same way as somebody who's older in their 70s or whatnot.
Well, and I think that's the right thing to say and to go with, because we don't know. And we want you around. We like you.
Yeah.
Hey, it's Devin. I just want to say the text messaging that you guys have for the push of this event was something that really got me to join. I know I've tried to like sign up for previous things and try to make it, but it always fell through. So thank you for that. I don't know if it's new or what, but it really worked this time.
Awesome, thank you. It's fairly new. But as, oh my goodness, I almost missed a really important meeting for my, my brains are so full, right? So I'm glad that it's working, and tell us when it gets to be too pesty. We're trying to, it's that fine balance, right? Of, hello, we're here, and oh, why are they not leaving me alone? So thank you, I appreciate that, Devin. Alrighty. Does anyone have anything fun planned for the weekend?
There's this community called Sequester, and if anybody's a fan of Big Brother or Survivor, like they have a huge like online, community that all nerd out about reality TV. But Sequester is like a Big Brother for the internet. So like it takes 18 or 20 people and it puts them all in chat rooms together where they have like room limits, and then they have like these twists and turns and have to vote out a person each round. And so I'm gonna watch like a villains versus heroes version tomorrow. I'm excited for that.
That's fun.
That's awesome.
I am hoping to get my tomato plants in the ground.
Good luck with that.
Yes. People are taking a break from schoolwork. They're writing master papers. Too fun.
We're watching meditation classes on Zoom with Tara Brock
Oh,
and Jack Cornfield, Cargold, and like
Joseph
that.
Goldstein.
Joseph Goldstein, our old buddies from our hippie youth.
Sounds great.
you'll have to send us the link so that we can see. Maybe we'll have to share it.
It's very nice, sure enough.
Yeah, that'd be awesome.
Tara Brock is great. She has a podcast that I listen to every day about meditation. Do you know her?
Only through people who work with her and on the web.
Oh, how cool. Yeah, share that. We want to see that.
Okay.
How's Adam surviving being out of school? Is he there?
I'm
He's
here.
alive.
Hi.
He's playing game.
He's playing games. I have a request, Adam.
Yeah.
Since we're not having camp this year, there's one thing we cannot not have this summer.
What?
You dancing. We have been watching you dance since you were tiny, and my summer cannot be complete without a performance, so I would like you to start working on it.
I'll try.
All right. Better put you up in the stars, and the Solder children better be practicing their instruments. Yeah. It can be a whole community variety show, even though if you weren't there, we can do some meditation.
Mhm.
It'd be awesome.
I want to watch other kids this year.
All right, well, you'll have to encourage them to do it.
Mhm.
You could totally lead an educational series on teaching other kids how to your moves, you know? Like, I think that'd be really fun. That could be an Ivy Leaders moment.
Yeah.
Cool. Thank you, you guys. What you're doing is very nice. Today is my first day. Adam helping me.
Oh, that's good.
That's good. Yeah. I'm glad you are doing these things.
Oh, good.
Yeah.
Well, we'll keep doing them. I was thinking after the May series that maybe people still want to do Friday nights. I know that's what you all voted for, but you want to do like a Wednesday or Tuesday, or are we all happy with Friday?
Friday is good. I love it.
Good. Okay. Just wanted to see.
Sweetie.
I want to know what's everybody having for dinner tonight.
I don't know. Bruno's cooking.
Nice.
Pizza.
It might be pizza.
I was cooking, but I stopped cooking when Adam said, we're going to order. So I rested today.
Good.
We are in Ramadan, so I cook every day like sambusa, some cultural food. But today, Adam said, Mommy, we're going to order pizza today, American food. Okay.
That's awesome. Amanda says she's having meatloaf. Nice.
Yes. I'm putting in the Costco mac and cheese for a night off myself for the family.
Good job, Steph.
I know, right?
We have,
beyond.
Nathan did come in to say hi, but it was like, hi, I have a show to watch, and ran away.
we have Costco salmon, frozen salmon burgers. We had one last night. We're going to do it again. Very nice.
Oh, that'll be really nice. Who was telling me that the individual salmon fillets that come frozen in the Costco are actually pretty good? Oh, girlfriend was. So I might try that.
We put in other seasoning to add to it, like coconut, garlic, miso, dill, pepper, you know.
It sounds really good.
Yeah, nice, in a little pan. Vegetables in the hot pot, quick. Silly.
That's awesome. Alrighty. Well, you guys want to keep chatting, or are you guys ready to go and eat dinner?
I'm getting hungry now. All this talk about food.
We'll sign off, but great to see everybody.
All right, let's all say thank you. Woo!
Thank
Thanks.
you.
Bye.
Bye. See everyone.
Goodbye.
Thank you to our sponsors. We had like 49 people signed on at one time, so awesome. Thank you, thank you.
Thank you.
Bye. Thanks, Stephanie.
Yes, thank you. Nice to see you, Katie.
Excellent.
Bye, everyone.